Thanks, John, and thanks very much for the opportunity to talk today. This has been really great putting this webinar together. My talk is really going to focus begin at the local level about what clinicians can do in terms of health services research within clinical settings. My own role is with the Allied Health Clinical Research Office here at Eastern Health, which is a large metropolitan health network in Victoria. My role is really about promoting and supporting and doing research within the health service, particularly focused on allied health services, but we certainly work in a very multidisciplinary sense. So, a wide variety of research designs can be applied to health services research questions. And in my talk today, I'm going to go through a few different designs, some of which might be often associated with other types of research questions, but can certainly be used to answer questions around delivery of health services. A lot of clinician researchers might be doing health services research, but they don't necessarily identify it as such. So we see this a lot, particularly within allied health. Any of the physios and OTs and speech therapists that we work with, they're often doing projects that are about health service delivery, but they kind of still think of it as a physio question or an OT question. So, part of this is about thinking about questions from different angles and about what benefit you can get by thinking of something from a health services research perspective. And I guess another aspect of this is that service delivery questions, from my observations, are often tackled with quality or redesign approaches. And there's nothing wrong with those approaches. They all, have an important role to play. But this is just about recognising that you can also approach these questions with rigorous research methodology, which does allow us to answer some questions sometimes in a more rigorous way, and just to be able to determine with less bias about whether the outcomes that you get from a project can be attributed to the interventions. So if we can go to the next slide, John, the first, yep, that's it. So first I'm just going to talk about a couple of randomised controlled trials that we've done around health services research questions, or that have been done at our health service. I shouldn't take all the credit for this first one. I wasn't directly involved, but my colleagues were. So, randomised controlled trials are, often considered, associated with very much with interventions and drug trials and things like that. But there's certainly no reasons that we can't apply these kind of methodologies to health services research questions at the clinical level. So this one was about evaluating the effectiveness of a 6-day versus a 5-day per week allied health service in rehabilitation. So this is led by Nick Taylor. I realise I should have Nick's name on this slide, and I think that's something with all of these slides. But this RCT involved 900 patients receiving inpatient rehab, and they were randomised to receive therapy on Saturday or their usual Monday to Friday rehabilitation. They looked at length of stay. They looked at length of stay, functional outcomes, readmissions, and also did a health economics analysis, including 12-month follow-up. And that RCT was able to show that a 6-day service reduced length of stay by 2 days, and patients had better functional outcomes and reduced costs. So by setting this up in a really rigorous way using an RCT, we were able to get some really solid evidence about the best ways to set up rehabilitation services. Skipping to the next slide, John, the next RCT is a much smaller level. That previous slide, previous project was a large NHMRC funded trial. This was a much smaller local-led project within our health service, but also applying that same kind of method. And this was about SMS reminders and failure to attend rates in outpatient physiotherapy. And although it was conducted in a physiotherapy service, the findings were very applicable to other services as well. So the question came up about whether it was helpful to send out SMS reminders in a service that had a reasonably high failure to attend rate. 679 patients were randomised to either receive an SMS reminder or not. 11% of the patients in the SMS group failed to attend their appointments, but that was compared to 16% in the control group. And what it particularly told us is that patients who received the SMS group, if they weren't planning to attend their appointment, they would tell us. So what it really meant was that those appointments could be rebooked. So it didn't necessarily mean that more patients attended their appointments than did before, but we knew if they weren't going to show up. And so you could make better use of the available services and resources. So, it showed that it can be an effective way to reduce non-attendance and make better use of health service resources. And again, rather than just putting something in place saying, let's give an SMS reminders a go, using health services research sort of framework and a more rigorous method really tells us that this is something that is worth investing in and something that we should be doing. Moving on to the next slide. Oh, sorry, can you just click a couple of times, John? I've obviously got some, yeah, just keep clicking through, that's fine. Yeah, that's it. So this is a control before and after trial. Before and after data is often collected as part of quality projects and smaller scale research projects. And as I'm sure you'll be aware, it's often a bit subject to bias. It can be hard to tell whether the outcomes that were achieved were really due to how much they can be attributed to the intervention. One way of just adding a little bit more rigour to a before and after trial is by adding a control group. So looking at the diagram there showing the research method, we had 2 sites here receiving usual care. This was an intervention looking at a new model of access and triage to see if it could reduce waiting time for a community rehab program without adversely impacting on other aspects of patient care. So we had 2 sites within this large health service that each ran in a similar way, similar management, similar patient groups, one slightly smaller than the other. They both ran using usual care for a 6-month period. We then introduced the new model at one site while continuing to collect data from the other site. And we're then able to compare site 1 pre to post, but we could also compare the intervention site with the control site. And we found that waiting times in the post-intervention period at the intervention site reduced by 40% without any adverse impact on other aspects of service delivery or patient care, and there weren't any significant changes at the control site. So that just adding that extra element to the research design gives us a lot more confidence that the change in the model of care was responsible for those reductions in waiting time and not something else that was going on at the service at the same time. Moving on to the next slide. Okay, so this one is a stepped wedge randomised control trial. This is a little bit more complex trial design. This is an NHMRC funded trial, so it's a much larger scale, but it grew out of that work from the previous slide where we were able to collect pilot data from the smaller control before and after trial. So based on that, we were then able to get a much larger grant to look at this same intervention to reduce waiting time and see if it could be applied on a large scale across a broader range of health services. So we had eight different services involved in this trial. You can see that site number 1 to 8 down the left side of the block there. And then along the top, the numbers along the top represent 4-week blocks. So the intervention, everybody had a period of pre-intervention data collection. The sites are put in random order, and we progressively introduced the intervention at each site. So, and then collected a period of post-intervention data afterwards, and it's then statistically possible to compare all that pre-intervention data across all the sites, with the post-intervention data at all sites, controlling for the differences between services. So that the cluster step wedge randomised control trial is becoming more popular in health services research. It's quite attractive to service managers in particular because all of the services get the intervention in the end. And there's also a bit less potential for contamination, which can be a bit of a problem in regular cluster randomised controlled trials where some of those in the intervention group might influence a little bit some of the people in the control group, particularly with service level interventions. And we were able to we've been able to find from this trial from this trial, we've been able to see that the intervention that was successful in a single service in the previous control before and after trial has actually been able to reduce wait times on a much broader scale with a more diverse range of services. Okay, so moving on to the next one. Just a couple of words on qualitative methods in health service research. So the qualitative health service research can be really useful in clinical settings, particularly for smaller scale projects. where there's perhaps more limited number of patients, or they're running something like a large cluster randomised controlled trial, or even a regular RCT is difficult. So this was one example, again, around waiting time. You can see a little bit of a theme to my work here. But so this project aimed to explore managers' perceptions of factors that affect waiting times in ambulatory services. We were really interested to know, well, what did the managers think about why their services had long wait times. There were semi-structured interviews with 26 service managers and senior clinicians, and the results were really interesting. Some things were very predictable. Of course, nearly everybody said, well, the reason we have long waiting lists is because we have high demand and we have insufficient resources. But we also found that there are a whole range of modifiable factors that that people come out with that were quite consistent across the various interviews. So things around inefficiencies in the way that referrals are processed, and the need for duplication at various stages, and non-attendance rates and things like that. So there were a whole lot of things that came out that could be changed, and I think one of the things that has been a factor in success in some of our previous trials is addressing a lot of those little things. We think it can reduce waiting times by 30 to 40%. Okay, and then I think we have one more example. Something's gone a little bit funny with the slide in the top corner there, but this was just a retrospective cohort study using an audit of medical records. This is a great example of an individual clinician level project, which could be seen, this is from a speech pathologist, it could easily be seen as a speech pathology project and look sort of seen with a speech pathology lens. But I think when you look at it from a health services research perspective, you get quite a different story. So the aim of this project was just to find out whether there's a relationship between communication difficulties and falls in stroke patients. So this particular clinician had observed a number of her patients with severe communication difficulties having falls while on the ward, and wondered if there was a relationship. She did a simple audit of 100 medical histories, and she collected a whole lot of variables around presence of a communication disorder, falls on the ward, and a whole lot of other demographic variables. And what she found was that the patients with communication disorders were twice as likely to have a fall while they're in hospital. And she also found that this was more predictive of falls than the score on our organisation's mandatory falls risk assessment tool. I think these sorts of falls risk assessment tools are probably familiar to a lot of people in the audience. And when you consider this project from a health services research perspective, I think it's really interesting to think that the health service are putting a lot of time and resources into assessing falls risk to try and reduce what's a really big problem in hospital settings. But yet the effort that's going into making sure that people comply with the requirements to assess falls risk using this particular tool may not actually be a good predictor of risk, particularly in this population. So by thinking from that perspective, it changes perhaps how we think about how we're going to disseminate the results of this study. Is it something that goes to a speech pathology journal, or is it actually something that goes to something with a much broader audience, which may be more about reaching health service managers about how we predict falls, and whether the one size fits all falls risk assessment tool is actually meeting the needs of services and patients when it comes to this really important issue. Final slide, John. Sorry. Yeah, so just a few questions to ponder really based on some of those examples. So, a lot of clinicians, I think, have research questions in mind that could be considered health services research, or maybe people are already doing health services research, but, why does it matter? Why does it matter if you call your project a physiotherapy project, or a stroke project, or a health services research project? Well, I think it actually does have a number of benefits. So, one thing is it kind of broadens your horizons in terms of where you look for opportunities. Perhaps giving access to different types of funding by looking at, in the funding categories that might be around health services research, or organisations that are willing to fund that type of research. It might be about reaching new audiences, and I think that previous example is a good one. It's about, you know, not putting a project like that into a discipline journal, but thinking about where else might there be an audience for it, and thinking about who else needs to know about it. It's not just speech pathologists and physiotherapists in that particular example. It's the people who are making the decisions about which falls risk tools we should be using within organisations. Some of it may be about fostering new collaborations and thinking about whether you know, there's value in seeking out a health economist, or, you know, somebody else that you might not be might not normally consider working with, to look at your questions from a new angle. Yeah, and it's about considering problems from new angles, about cost effectiveness and safety and feasibility. Identifying that an intervention, you know, works or doesn't work is not necessarily enough to get that message translated into practice. We also need to know whether it's practical to implement that intervention into a clinical setting. Is it going to be cost effective? You know, is it going to be feasible? So those sorts of questions, you know, are really important, and particularly knowing how tough it is to get things translated into practice. So I think that my intention has really been just to give a bit of a summary through a series of examples about how health service questions can be answered, you know, using health service research methods within clinical settings. And it's not something that has to, the speakers to follow are going to talk about things that are a lot more big picture. But, you know, I think, you know, clinicians even at very local levels can be thinking about health service research and how things can be viewed with this kind of a lens to get more benefit out of the work that we're doing in health services. Thank you. I'll pass back to you, John.